who is the medical director of the Washington Hospital Center Outpatient Behavioral Health at Trinity Square. He is a graduate of the University of Pennsylvania, where he majored in psychology with a minor in philosophy. He went to medical school at Sidney Kimmel Medical College and did his residency at Albert Einstein Medical Center in Philadelphia. He also holds a master's of bioethics from the University of Pennsylvania. He has been on staff at Washington Hospital Center for 10 years and has worked as the psychiatrist for the Medstar NRH Long COVID Recovery Program since 2022. So thank you for joining us, Dr. Radu, and I'll hand it over to you.
Thank you, Ben. I am super excited to present this material. As a lot of you know, I've been deeply invested, or you could say obsessed, with understanding long COVID and supporting our long COVID patients. I came here to Washington Hospital Center with the ethos of supporting the underserved, and this is a very underserved population. So I wish I could call my presentation an evidence-based approach to the management of long COVID, but we are not there yet. However, I think that over the last 4 years, we've learned a lot about this condition, and we have some tools to help support these patients feeling better. So I've spent a lot of time seeing long COVID patients, particularly with the Georgetown residents. I've spent tens to hundreds of hours discussing these cases with the Georgetown residents. But until recently, I haven't felt comfortable doing a talk like this, because the evidence base keeps growing, and some things we thought a couple years ago have been found to be not really the case, and new approaches are emerging. So my sort of like proximal trigger to put together this talk was a couple months ago. I was listening to a discussion between two long COVID providers in the United Kingdom, Dr. Benita Kane and a Dr. Sinclair. Benita Kane is a pulmonologist. Dr. Sinclair is a family medicine doctor. He focuses on an aspect of long COVID, mast cell activation syndrome, which I'll touch upon briefly. She is an advocate for children with long COVID. And hearing them talk shop about the tools they're using to help their long COVID patients, it dawned on me that I'm doing about 75% of the things they're discussing. So I think we're getting to a point that a canon of best practice is emerging. And my goal for this talk is to catch all of you up to speed with what that is. This is going to start more challenging. We're going to start with the pathophysiology of long COVID. I'm going to try to zoom through that and get to some of the challenges we have with clinical trials to get truly evidence-based treatments. And then we're going to move towards some of the treatments that we do have. Sarah, next slide. Okay, so what is long COVID? And I apologize, these slides are very busy. I really want this presentation to be shareable, where somebody can just read the slides and get a good amount of information from them. So what is long COVID? It is a complex neuroimmunovascular condition affecting multiple organ systems and causing significant disability. Major symptoms include fatigue, cognitive dysfunction, shortness of breath, chest pain, sleep problems, dysautonomia, which is dysfunction of the automatic processes of the body, gastrointestinal symptoms, and muscular and neuropathic pain, among many others. There are at least 200 symptoms that are listed as part of long COVID. The hallmark of syndromic long COVID is post-exertional malaise, although I sort of prefer the European language of post-exertional symptom exacerbation, since it's not exclusively a matter of fatigue and feeling lousy. Many symptoms can come out with exertion. And as I think most of you know, many of these patients have exercise intolerance, and even doing basic self-care can be a huge challenge. And definitionally, the onset of this condition needs to be within 3 months of a SARS-CoV-2 infection. For most people, the syndrome continues from the acute infection, but there is a minority of patients who make a presumptive recovery and then fall into long COVID symptoms some weeks to months later. Next slide, Sarah. So I would love to give you a standardized definition for this condition. There's no official ones right now. However, in the addendum to this talk, the National Academy of the Sciences, Engineering, and Medicine put together a manual that has a pretty nice definition. However, I discovered it after I'd already put the talk together, and it hasn't been like broadly accepted yet. I think it's really good though. So first, a meaningful distinction. When this when in 2020 we realized some patients weren't getting better, the technical term we used for long COVID was PASC, or post-acute sequelae of COVID. This is the overall umbrella term that describes any unexplained symptoms that appear after a COVID infection. And it encompasses a lot of stuff. End organ damage, for instance, cardiac or pulmonary damage during acute infection, complications of severe illness like post-ICU syndrome or severe dehabituation with muscle wasting. And importantly, the unmasking of occult illness. So conditions a person might have had prior to their COVID infection that were just laying low behind the surface. Most notably autoimmune diseases, which often can arise in the aftermath of a COVID infection. And this PASC also includes syndromic long COVID. So the patient community does prefer long COVID. And for the purpose of this talk, I'll be focusing on syndromic long COVID, which is a constellation of commonly occurring symptoms, which I mentioned in the first slide, that tend to cluster together into still undetermined subtypes. Now, there are common factors in most cases: the brain fog, the difficulties with exertion, pain symptoms, sleep disturbance. And it does seem like, based on many studies, that there are clusters and that this overall syndromic condition could be divided into different subtypes, but we don't quite know what they are. Now, it stands to reason that different phenotypic expressions or different symptom sets might point to different endotypes or pathophysiologies. However, this is an endlessly complicated condition, and different underlying pathologies can invoke sort of the same symptom presentation. So it's really hard to parse out. This is also a really variable condition in terms of its severity and its clinical course. Many people are affected with continuous symptoms. Others have more of a relapsing, remitting picture, where symptoms might get much better and then substantially worsen with or without a trigger. Some people, unfortunately, seem to have a progressive condition whereby no matter what they try, their condition continues to deteriorate. The most severe cases are entirely bedridden, unable to complete any of their ADLs, and may even require tube feeding and full-time nursing care. And some people do spontaneously resolve with supportive treatment or no treatment at all. I just want to note that spontaneous resolution, while it happens, is, I think, pretty rare, and it tends to happen more often early on. So, when somebody's had long COVID symptoms for a year, I think spontaneous resolution is possible. After 3-4 years, it might be more unlikely without care with some active ingredients. And importantly, the majority of patients, but only a slight majority, 55 to maybe 65%, meet criteria for ME/CFS or myalgic encephalomyelitis, which is a complex chronic illness that we've known about for at least 70 years that we just still don't have good tools for. In terms of the language we use to describe ME/CFS, long COVID, chronic Lyme or post-Lyme condition, I think some of the better terms to use are infection-associated chronic conditions. I personally really like Nancy Klimas, who's an ME/CFS expert, her description that these are all chronic immune activation syndromes. I think splitting hairs with what is the offending organism and what symptoms are produced in the individual, you can sort of miss the big picture that these are all conditions of immune dysregulation with a nervous system and a vascular component. Next slide. All right. And this is by far my busiest slide, so I apologize to all those who are driving or trying to view this on their cell phone. So what is the pathophysiology of long COVID? While I have to tell you that the full pathophysiology is not well known, we've made huge strides in understanding this condition. And I think we understand the pathophysiology of long COVID better than a whole lot of other conditions that we still have evidence-based treatments for. So in summary, long COVID is a vicious cycle of vascular and immune dysfunction, dysbiosis, the gut, skin flora, yeast. The organisms that colonize us can be thrown out of whack. Reactivation of latent pathogens, particularly human herpes viruses, most importantly, the Epstein-Barr virus that causes mono, which can move into a more active replication state in the aftermath of a COVID infection, and causing chronic systemic inflammation, which leads to tissue and organ dysfunction and damage. COVID is a vascular illness, and the role of damage to the endothelium, which is the lining of our blood vessels, is really central to the long COVID pathophysiology. There can be the development of microclotting, so small clots, fibrinogen-based clots with platelets clumping, which can gunk up small vessels, capillaries. This can lead to tissue hypertrophy and organ dysfunction, the brain, the muscle, the heart. Lung issues can occur due to vascular damage in the blood supply to the lungs. There's also both a central and peripheral nervous system component here. There's a hypothalamic pituitary adrenal axis dysfunction. I'll get to a little later. There's dysregulation in the production of cortisol, and notably, this seems to be occurring in the central nervous system, not in the periphery, not in the adrenal glands. There is brainstem dysfunction. I'm deeply fascinated in this, but we won't really have time today to touch upon that. Next month, I'm presenting a journal club about an immune activation center that was discovered in the brainstem that I believe has a role in this process. There can be vagus nerve dysfunction as of a piece with the dysautonomic symptoms. Vagus nerve, the nerve of rest and repose, and helps autonomic processes, digestion, helps coordinate cardiac function, control of heart rate. There are even some studies that suggest vagus nerve infection. And then importantly, small fiber neuropathy. Small fiber neuropathy is damage or dysfunction of the small nerves that innervate the skin, that innervate the blood vessels. And I think this is a really important and not well understood component of the pathophysiology, because I think a lot of the mischief here is blood vessels not being able to expand and contract commensurate to a person's output in terms of energy. At the cellular level, you have oxidative stress, which leads to mitochondrial dysfunction, the powerhouses of cells. There's in that setting the buildup of toxic metabolites, leading to cell death and dead and dying cells that are not able to be cleaned up then leads to a vicious cycle of more oxidative stress and cell death. So this is complicated stuff, and I think the biggest barrier to entry in understanding this condition is in zooming in and out between all the different levels. You have to start at the level of the whole person and what they're experiencing subjectively. You have to think about organ systems and organ function. You need to think about tissue pathology. Connective tissue has a huge role in long COVID, and then you have to think at the cellular level, and that's really hard. Even well-trained doctors in fields that might be more closely related to the pathophysiology, neurology, immunology, rheumatology tend to have a more narrow view of what they're aiming to treat, and this condition requires a broad knowledge of interlocking systems. There's a few unanswered questions. So is the mitochondrial dysfunction a cause or an effect? Is it sort of a late-breaking manifestation? I think probably mitochondria are working, they're doing double duty trying to sweep up this mess, and eventually they do crap out. But that's not completely clear. What is the role of autoimmunity? The demographics of these patients suggest this might be, at least for some, an autoimmune disorder. It's a female predominance. Average age might be in the 20s to the 40s, although it can happen at any age. And I will say the majority of my long COVID patients are females in that demographic. And then I think one of the most interesting questions that's being debated is what is the driver of the immune dysregulation? Is it reservoirs of the COVID virus that are hiding out, possibly in the lymph tissue of the gut, bone marrow, immune cells such as monocytes? Or is it viral debris that either we are not able to clean up, or people with long COVID are not able to clean up in the aftermath of an infection due to a dysfunctional immune system, or autoimmune production of some antigen? I'm agnostic. It could be both. It could be more one or the other, depending on the particular case. One suggestion that it could be the viral debris is something called post-vax syndrome, where rarely people can come down with very, very similar symptoms to long COVID after a COVID vaccination without being exposed to the actual virus. So there is precedence to think you don't need replication competent virus to get some of these symptoms. Another note is that while we are finding evidence of the virus remaining, at least in a latent state, in a lot of folks with long COVID, when we do our control groups in these studies in investigating viral reservoirs, some of the control group also has viral reservoirs, particularly in their gut, although it's a lower percentage. I'm going to stop for questions in a second, but this is complicated stuff. So I wrote down a metaphor that's been useful for me kind of understanding this. So I think one of the hardest things, especially for doctors to wrap their head around, is if all this stuff is happening and these people are saying they're so sick, why are the labs coming back pretty much normal? And why do the patients in our office describing these horrific symptoms look fairly well in most cases without like obvious signs? So for me, a key metaphor is think of a sailing ship which has several holes in its hull and it's leaking a moderate amount of water, the crew of the ship would have to work very hard to pour the water out night and day. And from afar, the ship might look intact, but it's not going to sail very well. And to me, that's an indelible metaphor for what's going on when you have people who are in this very energy depleted state, who aren't really doing a whole lot in terms of daily activities. Their immune system is working super hard to sort of stem the bleeding with these interlocking vicious cycles that are going on internally. I have a couple sort of graphic depictions of this process. I want to focus on the first one, then I'll pause for questions. Sarah, next slide. Okay, so this is from what I think is probably the best article, a Michael Peluso article that came out very recently that is focused on where are the areas of this disorder that might be amenable to treatment. So if you're looking at the slide, on the left-hand side, you see the upstream effects, and then on the right, with long COVID as the final downstream effect. So basically, in his view, and this is simplified, you have a COVID infection and then a systemic immune response, which activates both cellular immunity and humoral immunity, which can lead to autoreactivity or then a dysfunctional immune state and systemic inflammation. Concurrently, you have the virus directly invading tissues, or you have antigen persistence of viral remnants, leading to microvascular dysfunction. This leads to cell death. All of this leads to tissue, then organ dysfunction, all leading to the long COVID syndrome. Next slide, Sarah. So this one, I'm sorry, the writing is so small on this. I just want you to look at the gears turning. I think this conceptually is a nice slide from two of the foremost long COVID researchers, Akiko Iwasaki and David Putrino, who I've learned a lot from reading their papers and listening to their talks. So you see the gears turning first with a viral reservoir leading to latent virus activation. That this group was pivotal in identifying the reactivation of the Epstein-Barr virus and other herpes family viruses in the long COVID process. The gears turn with autoimmunity and tissue dysfunction due to viral reservoirs and the latent virus reactivation leading to tissue damage and dysfunction. And then below you have the vascular aspects here, the microclots, the platelet activation, neuroendocrine disturbance, and mitochondrial dysfunction, then leading to the most common long COVID symptoms. Next slide, Sarah.
Hey, Andy, you said you were going to pause for questions.
I'm here. I'm doing it, actually. I'm not even going to talk about this slide. This one just shows the different levels between the cellular and some of the tissue and organ manifestations. And I'm done with pathophysiology, and I'll answer any of your questions, and then we'll move into challenges and then treatment.
So, comment and question. Really nice talk so far. I have to admit, I haven't heard that much about mitochondria since medical school.
Same.
Great job all together.
Thanks.
You've mentioned measuring the viral load in the gut and other places. How do they measure the viral load?
Yeah, so it would be tissue samples, and so interesting point. So viral load is something that we can measure during acute infection only, and notably, speaking to the thought that viral reservoirs are a driver, people who are sicker and then sick for longer, and people who have been measured as having higher viral loads in their nose and throat during acute infection have a higher risk for long COVID. But in terms of checking long COVID patients for viral reservoirs, really what we're looking for is viral RNA. We're not finding replication competent virus just yet, but we have a lot of suggestion that it's there. I would say we have proof. What we don't have is proof of the causality between viral reservoir and the long COVID syndrome. And I think particularly because some people seem to have viral reservoirs, but their immune systems are not doing all this. So I think there's something there, but I think the condition might be heterogeneous. And I wouldn't bet the house that snuffing out viral reservoirs is going to heal everybody, although it should heal a good portion of patients. Other questions at this point? Comments?
Yeah,
Hi,
so
Andy. This is Steve Peterson. Just wanted
Go
to
for
find
it.
out, where are the viral reservoirs that are suspected?
Yeah, I
Thank
can,
you.
like, with confidence, I can tell you that it's the gall tissue, the lymph tissue of the gut. We have some idea that it might be in the bone marrow, as monocytes and macrophages seem to gobble up the virus, and then the virus might change the trajectory of those cells to remain living for longer than they should, and possibly contribute to immune dysfunction. And I think, there's been some studies showing like activated T cell uptake in the central nervous system, namely the brainstem and the spinal cord. But I think that's a little controversial, so I don't want to confidently assert it. And I just want to note that this isn't like there's a ton of virus hiding out in those places. I think, and I'm kind of avoiding the central nervous system aspects of this condition, because my belief is you treat this systemically and improvement in the neurocognitive and neuropsychiatric symptoms will follow. I think a lot of it is what the immune system is doing to snuff out these bits of antigen, or even virus that's hiding out either in biofilms or in cells in hard to reach places that the immune system doesn't really tend to be too active in normal cases. And then Dr. Fishman, you had a question?
yeah, I'm excuse me, I'm just wondering what attention has been paid, or if any of the studies have talked about. You said that most of the people you see with long COVID are women. I'm curious about if there's a particular demographic within those women, or what, I guess, what research has been done, if that's the case for most people who are doing the research on this.
Yeah. So I'll just say that so Akiko Iwasaki at Yale is studying whether estrogen production has something to do with this, and that might be linked to autoimmunity. I'm not as familiar with that. It's just there's too much out there. But there does seem to be a component of the hormones that females express more than men, perhaps being a contributor or a driver of symptoms. And Tony, with your question, how years of HIV research influenced diagnosis of long COVID, I'll get to that, I hope, a little bit with the treatment, which I'm going to get to in a second. Some of the foremost researchers in this arena have a foundation in the research of HIV, or contributors to the production of antiretroviral medicines, some of which have been repurposed for this condition. All right, Sarah, next slide. I just want to get to the treatment. Okay, so here we are. So this is Eric Topol, the founder of the Scripps Institute, who's written some of the best review papers on state of the knowledge base of long COVID. And so he says, and this is over a year ago, more than 3 years in, with tens of millions of people still suffering, this is the comprehensive list of validated treatments for long COVID, as established through rigorous randomized trials. This is a sad joke. It is an empty post. And so why is that? Why are we still 4 years, almost 5 years in, not producing like clear treatment? Next slide, Sarah. And I'll zoom through these, but basically we don't have standardized criteria for diagnosis, and it's really important for clinical trials to know who to include and who not to include. If you're including people with PASC who have like end organ damage, some of them are going to get better with time if they don't have syndromic long COVID. Without having confirmatory biomarkers, it's really hard to subtype, and it does seem like long COVID, the syndrome, might really be several different overlapping diseases, and we would need to know what they are to have clearer outcomes of our clinical trials. Another huge challenge is the sickest patients have a really hard time doing basic activities, so they're not going to be able to fly or drive to an academic institution to do this sort of elaborate testing and experimental treatment. So there's a selection bias with milder patients who might be more likely to improve regardless of what is being done. And then if you have an underpowered treatment, and it just so happens that there's more spontaneous resolutions in the control group, you can sort of get like a false negative with a treatment modality that might actually be effective. And that's sort of been a challenge so far with a lot of negative trial results that we've had. The big pharma is absolutely watching and waiting at this point. They just don't want to put the R&D money until we have a clearer idea of what sort of approaches will be effective. And I think this is really less about the development of new meds, although new generation antivirals against COVID, ones with better tissue penetration, are much needed. I think there's a lot of newer immunomodulating meds that could be useful, but the pharmaceutical companies are sitting this one out until academic centers come up with some better evidence for what might work. And importantly, a lot of negative treatment outcomes within those trials, there have been remarkable results. So, for instance, I think the most publicized was the like long course of Paxlovid, and so like a 14 or even a 30-day course of Paxlovid. There have been several trials so far that basically showed the majority of people are not helped, but a subset gets much better, and that might be a subset for whom the viral reservoir was a bigger driver. Likewise with monoclonal antibodies, the one that's used to protect immunocompromised people, EVU Shield, is being studied and is effective for some. IV immunoglobulin has been remarkably effective for a subset, perhaps patients with small fiber neuropathy who are showing a certain autoantibody that is present. But when you do a bigger trial, most people don't respond. And that's very frustrating because we have sort of high level treatments and expensive ones that may work, but perhaps only with 20 or 30% of patients. And that's not good enough to get FDA approval. I do suspect that each endotype, each separate unique pathophysiology needs its own fine-tuned approach, but without biomarkers, we can't get there. It's also really challenging testing combination therapies. We have precedents for combination therapy treatment in the oncology arena, but in oncology, we have these like really super fine-tuned tests where we can get the like a really narrow genetic analysis of any particular cancer to know what treatments might be useful in a trial. And we don't have any of that with long COVID. I didn't write it down, but another important one to note is the NIH RECOVER trial has been like widely panned by the long COVID community for wasting a lot of money on slow-moving observational research that really only reinforced findings from other groups and did very little in the way of testing agents that might be effective. Finally, there's a big ethical dilemma in trying to do trials for this. which is that a placebo or ineffective treatment arm can worsen health status because prolonged overexertion, like flying to get a treatment, can absolutely lead to a baseline decrement, which could be long-standing or even permanent. Next slide, Sarah. So I'll just touch upon this. So this is a pyramid of evidence from Dr. Gorski, who runs a skeptic blog that's focused on anti-vax propaganda. And so we are at the bottom of this pyramid. We are at the level of individual case reports, anecdotes, lots of anecdotes, some small studies that are basically cohort studies that aren't randomized, and a few small randomized controlled trials that were not really well powered. And of course, physicians are looking for like gold standard randomized controlled trials, or even systemic reviews that summarize multiple ones. Now, on the one hand, it's unsatisfying to be working with this kind of weak evidence base. On the other hand, I think it's really prudish to be waiting around for gold standard evidence to do anything, because these patients need help yesterday. Next slide. Okay, so finally we get to what is my approach. So admittedly, we're in the spaghetti being thrown at the wall era of long COVID treatment. We're trying a bunch of different things and just seeing what sticks. In terms of like, so this is to me like the thesis statement. It is morally unacceptable to wait for these high quality trials to initiate any treatment. And I think a lot of doctors are sitting this out. And I just think, even if this isn't in your wheelhouse, all of us need to understand this more, even if we're not going to be starting experimental medicines, to at least give the right counseling. And I've been deeply upset at doctors dismissing these patients and telling them they need to go to a psychiatrist. There's a big history of treating complex post-infectious conditions as psychosomatic, and I think that's really not the case. So when many interventions can be at least a little bit effective, you want to start with the most benign treatments and sort of move up to treatments that might be a bit more harmful. You can do baseline labs. I think it's useful, but not necessary. I'll just note that the most common aberrations or issues we see in these patients might be a low cortisol or a dysfunctional cortisol, and aberrations in the lymphocyte subset panel, suggestive of exhausted T cells that are just dysfunctional after being activated for so long. I personally do check Epstein-Barr virus, because it's been well known for a while now that reactivation of Epstein-Barr in complex post-infectious illness can be at least a contributing factor to the systemic pathology. You can check clotting labs, you can check iron studies, and you can check markers of inflammation like CRP. I wouldn't expect much. Sometimes patients feel that there's a value in seeing something wrong when they've been told nothing is the matter for years. There are some newer studies, cytokine panel, and then a microclot assay, but these aren't fully validated and they're really expensive. Next slide, Sarah. So finally, getting to the treatment. So this is the consensus stuff. Do not gaslight them. Treat them with intellectual humility. Even if you don't have the tools, it's so important for us to support them and to believe what they are telling you. The alpha and omega of long COVID treatment right now is pacing and balancing activity with rest to avoid exacerbations of symptoms or crashes. And it's important to note crashes do damage. You are perpetuating the pathophysiology when you move outside of your energy envelope, when you have this illness. And a good rule of thumb is rest twice as much as you think you need, and then take all the things you want to do in the day and cut that list in half. That's really important advice, because if a person isn't doing that, all the specific treatments we might give them just aren't going to be effective. And this is simple in theory, but hugely challenging in practice, where for some of the sicker patients who are maybe homebound, the choice between doing their ADLs and socializing or prepping healthy meals or getting enough rest. I mean, if there's really a grim calculus around what a person can do with their almost empty gas tank. And then attaining adequate sleep, reducing stress, maintaining social, emotional, nutritional, and hygienic needs are also really important and really challenging. It helps a lot to have a supportive network when you have this condition. And it helps to have financial resources as well. Lastly, biometric tracking can be hugely useful for the dysautonomia component, tracking heart rate, where people with dysautonomia might have really sudden spikes with positional changes, checking pulse ox as some patients are having O2 desaturations is important. And then heart rate variability, which is sort of a proxy for the stress response, can sort of be a measure that helps people with pacing, letting them know when they're about to crash before it actually happens. Another notable point is that crashes for most patients are an immediate 14 to 72 hours is most common. So it's kind of hard when you might not realize you're overdoing it, maybe just sitting on your computer or watching TV, and then getting hit by worsening symptoms a day or two later. So pinning down when your PEM happens is really important. And this is really like an ounce of prevention is worth a pound of treatment in terms of the crashes. Next slide. So I'm not going to have the time to really give justice to these co-occurring conditions, but it's super important that we treat the dysautonomia. We have a playbook for treating dysautonomia. The most common version is POTS or postural orthostatic tachycardia syndrome, wherein positional changes from lying, the sitting, the standing leads people to feel very sick, very dizzy, and precludes their ability to stay mobile for a while. And electrolyte blends, namely sodium, can help. Wearing compression garments, beta blockers, which we can provide, and then some heart failure drugs, midodrine and vabradine, have been useful for the dysautonomia aspect. I just want to note that the dysautonomia symptoms speak to these people are having trouble with the pooling of blood in their extremities, and they're not getting enough blood flow to their brain, particularly with the positional changes. So there is an aspect of cerebral hypoperfusion or mild hypoxia to the brain and other organs driving some of these symptoms. So mast cell activation syndrome, MCAS, pretty common syndrome. It might be like 15% of the population. These are people who are prone to drug and food allergies. They might have a history of anaphylaxis. They might have random rashes that are triggered by certain foods or certain environmental triggers. And for MCAS, doing a low histamine diet, which is tricky, and adding common, safe antihistamines, often in combination or high doses. So I use Zyrtec, I use hydroxyzine, and the GI antihistamine Pepcid or famotidine can be useful. And then an immunologist can try some stronger mast cell stabilizers if that isn't helpful. Getting these two things under control can really move the dial in terms of improving symptoms and quality of life. Finally, a lot of patients with long COVID are on the hypermobility spectrum. They have defective collagen production that affects both their joints, all their connective tissues, and the lining of their blood vessels. And so ruling out some of these structural abnormalities like craniocervical instability and then sending them for specialist care can be useful. And then finally, I think physical therapy is a double-edged sword when it's focused on autonomic conditioning and is gentle and isn't about pushing a person to exert more, it can be very helpful. But unfortunately, there's a lot of physical therapists out there who are making patients worse on the assumption that this is somewhat psychosomatic and the patients just need to be pushed to more activity, which is really harmful. Next slide, Sarah. So this is the canonical treatment right now, low dose naltrexone, which we start at a fraction of the usual dose, 1 milligram raised slowly in 1 milligram increments to the target dose of 4.5 milligrams over 3 months. We don't know quite why this works. We think it's modulating endorphins at the lower dose. It seems to have some positive aspects for inflammation and boost the innate immune system, natural killer cell function, and it might be helping with neuroinflammation. And it's subtle. It can help with pain, cognitive dysfunction, and the crashing PEM. And it's been used off-label for years for fibromyalgia, ME/CFS, MS, and even end-stage AIDS pain. It has a really favorable side effect profile. It's mild, it's well tolerated. It is a bit expensive since it requires a compounding pharmacy. And the benefits tend to be modest, but about 70% of patients are responders, and that's consistent with my experience. I've had a few patients get a lot better with this medicine, and I've had a few non-responders, but it's at least not doing a lot of harm. Next slide, Sarah. So weak to moderate recommendations, SSRIs may be helping through an antiplatelet and an anti-inflammatory mechanism, and they are treating the comorbid mood and anxiety disorders, which are common. There's dysfunction of gut-brain axis and serotonin transmission. So this might be helping a bit. I found them to be really effective for the mood symptoms, but in my experience, they haven't moved the dial on the core syndromic long COVID symptoms. Low dose Abilify is an alternative to low dose naltrexone at a fraction of the dose we use. And I think it's having a similar effect to low dose naltrexone. It is just a dopamine endorphin modulator at that tiny dose. And we have a pre-long COVID trial out of Germany that showed about 75% of patients had at least mild benefits in terms of their symptoms on that medicine. And I've used it a couple times. I also do use Valtrex or other herpes antivirals from time to time when I have serology indicating active or recently reactivated Epstein-Barr virus. And I've listed some other herpes family viruses that can be accomplices in the long COVID pathology. And the combination actually of low dose naltrexone and Valtrex, typically a gram a day, has been pretty helpful. Some of my patients have said they're about 50% better after about 6 months on that treatment. One really interesting treatment that's coming up is a repurposed HIV medicine, Maraviroc, combined with a low-dose statin. And this is theorized to treat the vascular inflammation. However, this is proprietary. The patent is owned by this group, Incell DX, Dr. Bruce Patterson, who was an HIV researcher for many years. It is extremely expensive, and this organization does not take insurance, and they really haven't published too much. But his basic idea is that the best strategy for healing these patients is to improve the vascular inflammation, and then other improvements follow. He's released one cohort trial showing some improvement, nothing randomized, and I've heard a lot of good anecdotes, but we need better trials to prove this is right. Some docs are repurposing PrEP Truvada, which shows lower long COVID rates among PrEP users and might have immunomodulatory effects in long COVID. Next slide. Yeah, so a couple other things that I'll just gloss over are a repurposed myasthenia drug, pyridostigmine or mestinon, which might improve transmission along the neuromuscular junction and improve the ability of blood vessels to contract and expand as needed, which helps dysautonomic symptoms and vagus nerve function. Then guanfacine has been used. The Mayo Clinic innovated this treatment for the brain fog, so frontotemporal brain activity. I'm not sure how helpful either of these meds are for patients because the side effects can be really rough. Also, metformin has been used for immunomodulatory effects and to help what's called inflammaging, which is a conjunction of inflammation and aging. And it's been found that metformin helps prevent long COVID, and so it's sort of a logical jump that it might improve long COVID pathology, but that hasn't been determined yet. Next slide. So the supplements, this before we had any of this stuff, patients were already working hard, communicating online on Reddit and Twitter, experimenting with different treatments. So I just want to highlight here, you've got some antioxidants, you've got omega-3s, CoQ10, very commonly used for mitochondrial function. But the number one supplements or class of supplements that have been found to be useful are these proteolytic enzymes, nattokinase, lumbrokinase. These have blood thinning and perhaps antiviral effects. They're widely used in the long COVID community, and they might have these blood thinning effects without increasing risk of bleeding. Next slide. A couple more interesting ones, and I'm just going to have to gloss over this. High dose melatonin might help neuroinflammation and help lymphatic drainage, which is clearing toxins from the central nervous system. And then some sort of cutting edge stuff that's maybe not ready for prime time yet is plasmalogens, which are the building blocks of neurons and glia cells of the central nervous system. And then peptides, which are really buzzy but haven't been well studied for their tissue healing properties, and one in particular, BPC 157, which might promote the formation of new blood vessels, but has no human safety trials, so we just can't recommend it yet. Next slide. Okay, so these are interesting. These are the non-pharmacological treatments. These are being studied right now. Mount Sinai is doing an RCT in both vagus nerve stimulation. Here you have a picture of somebody stimulating the vagus nerve at their ear. It can be stimulated at the neck as it leaves the cranium in the carotid sheath with a very low voltage electrical stimulation. And this is to support parasympathetic tone and for anti-inflammatory effects. However, contrarian people who think this isn't a great idea say there's vagus nerve dysfunction, but it might not be hypofunction. So this might be a risky intervention for people when we're not sure exactly what's wrong with their vagus nerve function. Red light or infrared light therapy to promote mitochondrial function, perhaps improve tissue hypoxia. This is being studied. The fancy term for this is photobiomodulation. And I am all about this, although the evidence base is really weak right now. And then some patients are benefiting from hyperbaric oxygen treatment, which you see in that little iron lung-like device at the bottom. This is theoretically improving tissue hypoxia, but it's very expensive and requires multiple treatments to be effective. I do have a couple anecdotes of patients who have, my own patients who have improved with this treatment. Next slide, Sarah. Controversial treatments, and I'll really stop for questions after this. So first of all, in South Africa, the group that did a lot of work with the microclots and the clotting pathology has invented a triple anticoagulant therapy, which combines three different blood thinners to break down the microclots and the vascular pathology. And so this has been found to be effective in a few small trials that I don't think were randomized. However, the bleeding risk cannot be overstated. And the key concern here is what is the number needed to harm, even if this is an effective way to treat, if even 1 in 1,000 patients suffers a catastrophic brain bleed, that is way too much. And I don't think this can be recommended broadly yet. Some patients, likewise, were doing plasmapheresis, filtering their blood, similar to dialysis, and taking out proteins in the blood and repleting the blood cells. This is to reduce the microclot load. Some anecdotes are saying patients are getting
Hey,
better.
Andy,
Yes.
we are out of time.
Okay.
And
All right. Okay.
you promised time for questions.
I know. Okay, low dose nicotine patches, I think, is actually an interesting idea. I do not recommend psychostimulants. I think pushing people to have more energy is robbing Peter to pay Paul. And then two treatments that are widely panned in this community is a psychosomatic focus, CBT, on illness beliefs, and then graded exercise therapy are widely reviled in the patient community. Next slide. So future directions, we need subtyping and we need personalized recovery plans. We're gonna need, and I think we will see in the next couple of years, combined therapies with immunomodulators and newer antivirals. There is going to be collaboration between anti-aging medicine and the practitioners of complex chronic disease treatment. And of course, we need to improve equity and access to these treatments to disadvantaged populations and to combat ableism to make society a safer place for disabled people. I'm done. Questions?
I have a question. Where do we start?
So
wait, let me finish my question. I have somebody who says they come in with long COVID. Do I send them to you? Do I send them to immunology? And specifically focusing on the Medstar system, there used to be a research group that I think kind of fell apart where we were sending folks.
So long COVID has an NR. I think the PM&R department at NRH is the quarterback right now that's sending people for specialist care. But I'm trying to sort of quarterback it myself with my long COVID patients. It takes a team-based approach. Nobody can tackle this whole thing. But I really think any provider in any specialty can start low-dose naltrexone, can start an SSRI for comorbid depression, and maybe move the needle and can become more knowledgeable around the pacing and what supportive measures might be useful. So I don't know that I have a straight answer for you, but if you want to send them to me, I'm always happy to see these folks. Other questions?
Yeah, I have a question, but I don't know whether we have time or not.
Go for it, Chen. I'm happy to stay on an extra 5 minutes if people need to drop off.
Okay. Well, I have thanks for the timely presentation, because I just referred a patient who has a long COVID. She referred to me because of fatigue, anhedonia, insomnia, poor appetite, weight loss, and some kind of vague anxiety, and she started feeling depressed because of her dysfunction. Her PCP and the doctors in the family have tried everything from the SSRI, the metazapine, trazodone, cyproactidine for her appetite, melatonin, Ambien, Medstar, Ativan, everything, and she get a side effect with all those medication.
Yeah, so part of this, Chen, I'm sorry to jump in just for the sake of time. So with a lot of these treatments, patients may get worse before they get better. That's one. So you have to prep people for there might be a suck, and it might even indicate the immune system reconstituting and starting to take hold. So some side effects with some of these specific treatments are worth persisting through. But then this somebody who's failed multiple layers might be appropriate for some of the more experimental treatments, the hyperbaric oxygen, the Maraviroc plus Pravastatin, the red light therapy, I